Hello, everybody, and welcome. Thanks for joining us today. My name is Matt. I am the clinical director of the Midwest Concussion Clinic. I'm joined here by Dr. Lazoff. Dr. Lazoff is our medical director. Just wanted to say thank you for joining us today as we talk a little bit about concussions and kind of what to expect over the first 48 hours. Just wanted to talk to you a little bit about, kind of what concussions are. Today, we're going to dispel some myths about what concussions, what you may know, what you may not know, what you think you may have heard in the past, and kind of where concussion knowledge has changed over here the course of about the last 18 to 24 months. So the overall goals today are, number one, introduce ourselves and show you who we are. But again, want you to be able to differentiate between concussion myths and concussion facts. Number two is we want you to understand that you can reduce overall symptoms initially following concussions. It's not a sentence that, hey, I've been diagnosed with a concussion, I know I'm going to be miserable. It's just, I got to get through it. So we're going to come up with a couple of techniques and talk to you about ways to help you get through those first 48 hours. And then finally, give you some tips and tricks and tools that you can use to optimize your brain for recovery following the initial injury. So a lot of it is, everybody's got that sit and wait mentality. I've got a concussion, now what? So really what we're the final goal for today is to sit there and give you some ways that right off the bat, you can help speed up your recovery. You can talk to your athletes, you can talk to your students, you can talk to your children, you can talk to a family member. You can learn these and store these for yourself and use these as a way to kind of optimize the brain for recovery in that first initial time frame after a concussion. The big key, if you forget anything else that I talk about today or anything else that we cover, is that no matter how long a concussion injury happened, so how long ago the injury actually occurred, concussions are treatable. So even if the concussion happened 10 years ago and you still have some chronic dizziness, you still have some focus difficulties, some memory difficulties, some slurred speech, some balance difficulties, if you're avoiding certain body positions or head positions because over the course of the last decade, I'm getting nauseous. These are treatable things that we can fix with the right evaluation and the right treatment plan that's tailored to you. Big picture, concussions are treatable. So the first person I want to introduce you guys to is Evie. Evie is a student athlete of ours. She graduated from our clinic. She was involved in an accident that left her with a concussion, and she just kind of wants to sit there and give you the patient point of view on what to expect following a concussion.
Any symptom that you think of when you have concussion, I had all of it. So it was just super bad headaches, very nauseous, vomiting, sensitivity to light and noise, and just very out of it. I don't think people understand most of what a concussion is. It's one of those things that is invisible. You can't see it, so people don't get it. They just think kind of it's like a headache, I would say. Like a lot of people just believe that it's a head injury and that it should go away. Definitely when it's a more severe concussion, people don't understand that all concussions are different, and it's not just like, oh, my friend had a concussion that lasted a week and you should be better in a week. Like it's very different and depends on the person. I think people don't get that, and they don't get the mental side of it that's just as hard to deal with as the physical symptoms. It's definitely like I said, a different concussion than it was before, more severe, but I would not have recovered as quickly if I wasn't here. And just having that support has definitely completely changed the mental side of it, just from being like validated and this is what's wrong and this is how we're going to fix it, and just having that plan has definitely made a world of a difference for me.
So when Evie came to our clinic, for her, the injury couldn't have happened at a worse time. There's never a good time to get injured, but it happened in the middle of her basketball season. So when she was playing basketball, she was your typical senior student athlete, was loving the game. High school was great. Everything was exciting. Then her injury occurred. Now, she didn't get it during basketball, but her injury occurred, and it kind of derailed everything. With her, it was a very difficult injury to process because it was in the middle of that postseason run. So she was excited, geared up, ready to go. And then all of a sudden her world comes to a screeching halt. When you see that happen, or when you have a concussion happen, it's not like an ACL tear or a broken arm or a broken leg. People don't see the injury. And when you see somebody who, tore an ACL, they've got an immobilizer on, they're walking around on crutches, pretty easy to sit there and say, hey, I think something's wrong with their knee or their leg, and that's why they aren't playing. When you see somebody with a concussion, the first thought, unless they're wearing sunglasses and earplugs sitting inside, is, what happened? Are they suspended for academics? Are they suspended because they got in trouble doing something they shouldn't have been? Violation of team rules? Did they quit? Did coach just bench them and say, hey, you're not going to play anymore? And so what Evie talked about is, when people see the injury or talk about concussions, they expect you to be better right away. But what happens when you don't get better right away? And that's kind of what Evie had to deal with us, is it took a little bit longer for her to recover. And that longer that recovery happened or took, the more she had to deal with the negative psychological side of things that she talked about. Now we're just going to go through and kind of talk about why some of those things are changing and what to kind of think and expect moving forward to kind of change and transition our concussion knowledge to to 2021. Okay. So the first question that we talked about, concussions are a bruise to the brain. We touched on it a little bit, that's a myth. It's a disruption of the electrical signal. When we sustain a concussion, the electrical signals in the brain, when we're hit, when we have that whiplash or we have that contact to the head, the axons that carry the electrical signals throughout the brain stretch. When that stretching occurs, the brain sends all electrical signals out at the same time. When that happens, we get kind of stunned, we get dazed. If anybody that's ever had a concussion, they go through it. When that initial hit happens, they kind of get that little glassed over feeling or that glassed over sensation where they feel dazed, confused, kind of out of it, disoriented, or they may lose consciousness. You don't have to lose consciousness to sustain a concussion. It's the general disruption of the electrical signal inside of the brain. When that electrical signal disruption happens, all of the electrons fire at the same time inside the brain, and the brain goes, oh no, that's not good, and starts to slow everything down while it goes through kind of a system reset or a overview of what's going on. It kind of takes a minute for your brain to sit back there and say, okay, what happened? How is everything functioning? Let's go through all your life support. Is our breathing functioning? Is our heart still functioning? And your brain goes through and connects the dots and says, okay, now that we've gone through kind of damage mode or crisis mode, let's start the healing process. The good thing about the brain is from the initial injury, the brain has already started to heal itself underneath of what we're doing. So the brain started to repair the neurons and the axons and the neural connections that are all disrupted post-concussions, and all the things that are able to carry the electrical signals in the brain start to repair themselves almost immediately after a concussion. Now, there are 70 trillion to 100 trillion connections inside the brain that we know about to this point. If you think about counting from 1 to 100 trillion, it's going to take a long time. So what we've got to do is our brain takes some time to repair those axons, repair those neural connections, create new connections. And that's where kind of our rehab process comes into play, is we're helping facilitate that growth and facilitate that healing process that happens underneath with concussions. The second myth is concussions only happen in sports. Right now, concussions are the second to third leading cause of concussions, depending on the research that you look at. So concussions get a bad rap in the media. They're always linked to football. If you look at the NFL concussion research and the NFL concussion lawsuits that are going on, everybody's going after football. But what people don't realize is there are so many other things that are involved in concussions and in concussion management. So when we have concussions, most concussions are sustained through falls. All age group experience falls. The number one reason for emergency room visits from the age group of 11 to 15, and then those over 55, were all from fall-related brain injuries. So if you think about that, our young kids fall, our high schools fall, our middle-aged athletes fall, our seasoned people fall. as we age, fall risk goes up. When we fall, we lack the ability to control the forces that are going through the brain. And that's why falls are generally the #1 cause of concussions worldwide in everyday groups of people, in all groups of people. The second leading cause is motor vehicle accidents in sports. They kind of go hand in hand, depending on the research you look at. Sports is #2. Depending on the research you look at, motor vehicles is #2. So motor vehicle accidents, if you think about, most people have either been in a motor vehicle accident, seen a motor vehicle accident, whether it was a fender bender or a rear end collision, a car got totaled, the force that goes through the car in those situations has to be transferred somewhere. So in terms of brain injuries, concussions, it takes about 120 newtons of force through the brain to get a concussion. Okay, if you think about a rear end car accident, if you have somebody going 30 miles an hour that gets rear-ended from behind, the car's going 30, they're a restrained driver that weighs 150 pounds. Their brain and the motion and force that's sent through their body is up to 5 times the amount of force required to sustain a concussion. I'm not going to pretend to lecture you on physics, but I can tell you 5 times the amount of force that's required to sustain a concussion goes through the body on a very basic, quote unquote, basic motor vehicle accident. That's a lot of people that you don't really think about that need assessed for concussions that kind of get overlooked, because if they're transported to the emergency room, it's not, hey, let's look for a concussion. It's let's fix the shoulder. Let's fix the knee injury. They're complaining of abdominal pain. They're complaining of cervical pain. They're, in the worst case scenarios, we have life-saving measures that we have to do. And at the end of it, when you're discharged from the emergency room, when you're discharged from your trauma center or your ICU, depending on the severity of the accident, if you look at like the 12th page of your paperwork, it says you may have sustained a concussion. You should probably follow up with somebody if that happens. And a lot of times it gets overlooked because we sit there and say, okay, let's keep them alive first. And then it's on them to follow up for the rest of it, because concussions are not as life-threatening as, a subdural bleed or a femur fracture or some of the other injuries that may come with a motor vehicle accident. The third leading cause of concussions in the United States, or the fourth leading cause of concussions in the United States, is one that's growing rapidly right now. It's very concerning for all of us. It's also very hard to get research into. So it's listed as the fourth leading cause of concussions, but it's probably a little bit higher than that, is domestic violence. For good reason. There's a lot of difficulty getting research into domestic violence. It's a terrible thing that happens. Luckily on our end of things, we're there to help and fix things. I have had a couple patients, unfortunately, that have been through domestic violence. And it's one of those areas that me personally, I like to work with and I like to help, because it is a group that's often needs more assistance than they get in certain times. So unfortunately that number is growing rapidly. But the other really, really concerning thing about the concussion numbers is they think up to 50% of concussions go unreported in the United States. That's not good. That means we're catching a huge number of concussions, but it's almost double of what we think is going on. And in terms of that 50% number, is a low ball number that we think go unreported. Okay. So next we're going to play a video clip of another patient of ours, Jeff. Jeff's going to talk about one of the causes of concussions that we just touched on, falls.
I was going into work early in the morning, tripped over the sidewalk, couldn't see it, and was unconscious for a while. Luckily, I came to in the business next door, took me to the emergency room. Every day I have headaches and neck aches, blurriness and vision. With my job, I'm usually on the computer 8 hours a day, and I can't be on it probably more than an hour without getting blurry vision and headaches and all. I spent the first 2 weeks before I got over to Dr. Laszloff and Matt resting, and nothing seemed to help. Matt gets me motivated to do stuff and to exercise and all, so that's helped a lot with my attitude and all.
So Jeff touches on a lot of things in that interview, And one of the things that he touched on was, he did sustain a fall, and he's also part of that group that we don't necessarily think of for sustaining concussions. If you look at concussions, it's all, a lot of the research and a lot of the media pushes sports related, a lot of falls. When people associate falls, we think elderly. Jeff, middle-aged man, walking into work, tripped over a curve, knocked unconscious for an extended period of time, all from a fall. Jeff's been working with us. We'll talk a little bit more about his story down the road, because he does talk a little bit about some of the psychological side of things post-concussion that we'll touch on in that first 48-hour recovery. The next myth that we're going to dispel is it's okay to take medications after a concussion. In all honesty, this was a little bit of a leading question. It was kind of a trick question. Over-the-counter medications following concussions can cause more harm than good, and a lot of times in a lot of situations, but acetaminophen and Tylenol post-concussion can help take the curve or take the edge off some of those really bad symptoms that happen initially. The one thing we need to avoid with Tylenol is we don't want to continuously take Tylenol over an extended period of time, because we can develop what are called rebound headaches. Rebound headaches are headaches that occur once the Tylenol starts to wear off, that are an artificial headache that are actually worse than the headache was before we started taking the medication. So if you think about it, I'm taking Tylenol every 4 to 6 hours for the course of that first 48 hours. As that wears off in that 3 to 3.5 hour range, my headache is going to come back worse than it was if I'd have just avoided taking the medication altogether. We have a phenomenon with concussions that, it's the fall and the mechanism of injury leaves us open to more serious injuries, more subarachnoid hematomas, more subdural hematomas, which are bleeding that can occur in the brain, which is why most healthcare professionals will tell you to stay away from anti-inflammatories. Ibuprofen, Mobic, over-the-counter anti-inflammatories that generally get tossed around, especially in the athletic population, as this is the miracle medication that you take when you feel bad and it's going to make you feel better. So we want to avoid over-the-counter medications, ibuprofen, Mobic, Aleve. We want to avoid all of those in general, but we want to avoid the Tylenol as long as we can. Some of the other medications that people don't think about that may cause some issues post-concussion are antihistamines, allergy medications. For whatever reason, there's no real rhyme or reason why it happens for some people, why it doesn't for others, but antihistamines can have a negative side effect for people that are recovering from concussions. So when people take antihistamines for anti-inflammatories, it kind of heightens the system. It makes the system more alert and the overall body system more alert. When we have somebody with a concussion that they take an antihistamine, there's a potential for symptoms to increase, dizziness to increase, headaches to spike within that first 30 minutes of a antihistamine getting broken down into your body, that we tend to tell our patients to avoid antihistamine usage unless absolutely necessary through the initial recovery period. Now, I can't tell you that every 18-year-old that's had chronic allergies that are 3 out of 10 that takes antihistamines is going to experience symptoms the first time or the second time, which is why we tend to give a blanket statement of avoiding antihistamine use overall. I know this is one of the areas that Doc likes to touch on, but with the mic, I'm going to talk about it a little bit here. In our clinic, the philosophy overall in our clinic is we don't like to use medications to help headaches as long as we can to avoid slowing the brain down. A lot of low-dose antidepressants are used for concussion symptoms, are used for headaches, are used for sleep difficulties that we can use in our clinic that Doc likes to prescribe if long-term sleep difficulties happen, if we're not getting improvements in headaches through the initial time period or the initial evaluation process that slow the brain down. When the electrical signals are disrupted post-concussion, the brain slows down physically, and that starts to make it, the brain, we're trying through our rehab process to speed the brain up. So if we have medications and an injury that are slowing the brain down, trying to speed the brain back up becomes more and more difficult. So we try to avoid the usage of medications throughout the entire recovery process if possible. But if we need to, Tylenol and Excedrin migraine, following that initial 48 hours can be utilized to take some of the edge off and curb some of those symptoms as needed. One of the biggest myths that we're fighting all the time in our clinic is that you must get hit in the head to sustain a concussion. You don't. Whiplash is one of those injuries that's always grouped with concussions because we've talked about it. I'm not a physics, major, but the force required for a concussion is 120 newtons. The force required for whiplash is 5. So if you sustain a concussion, you're going to have a whiplash injury of some form or another. Now you add on the fact that you don't have to have a head injury that hits the ground. You don't have to have head contact with another person, with the steering wheel, with the ground. The whiplash movement of the head and the rapid movement or body movements or the whiplash effect following a collision generates enough force through that brain and through the brain stem to sustain a concussion as well. I hear it all the time in our clinic. Well, I don't remember hitting my head, but why am I dizzy? Why am I nauseous? Why am I having trouble concentrating and remembering things? And we remind them that you don't have to get hit in the head to sustain a concussion. The last one, concussions aren't a big deal, okay? 3.8 million concussions a year, according to the CDC study that was done back in 2018, that 3.8 million concussions in the United States alone go reported through athletic trainers, physicians' offices, emergency rooms, ICU departments, with up to that 50% that we talked about earlier that go unreported for various reasons. I don't know what concussions are. I just thought everybody got dizzy after, a rapid head movement or a fall to the ground. I didn't want to tell anybody because I didn't want the athletic trainer to pull me out. I didn't want to miss the next game. I don't have the time to take time off. I can't afford not going to work. So symptoms go unreported for a variety of reasons. But that 50% number that is suspected on the amount of unreported concussions continues to rise year to year. And that's what a lot of our clinic fights with is education of athletes, education of parents, education of other healthcare workers, education of coaches, administrators, family, loved ones. We're trying to spend a lot of time educating everybody on what concussions are, what to expect, and how we fix them and treat them, trying to fight the go sit in a dark room and rest and update our treatment plans and protocols throughout Fort Wayne and the surrounding areas. Ideally, everybody gets the rehab and the evaluation that we need, and that's our goal moving forward, is to get everybody treatment and the evaluation that they need following a concussion injury. So let's break it down. Concussion symptoms always occur instantly is a myth. There's a phenomenon called delayed onset concussion symptoms or delayed onset concussions, to where the adrenaline's going for an athlete, an individual who's fallen, a motor vehicle survivor, accident survivor, a domestic violence survivor, that the adrenaline is so high that the body protects itself and starts to sit there and go into that fight or flight mechanism that we talk a lot with our patients about. Following that initial injury, there are times where a patient may not know or may not experience symptoms in that first 24 hours. They may go to bed that night going, I'm okay. I got a small headache, but I may always have a headache after a fall. I got a small headache because I just got done playing a basketball game. I didn't hydrate really well, or I didn't eat very well. I may have a headache when I went to bed because I didn't sleep the night before, or I had a hard test during school. And then they wake up the next morning, dizzy, nauseous, mentally foggy, trouble concentrating, ringing in their ears, vision problems. And they sit there and go, what is going on? Am I sick? Did I just sleep wrong? My neck hurts because I slept weird on the pillow. That's it. Maybe I just didn't sleep at all last night. And then what they don't realize is the event that took place at the night before or the day before has actually caused the symptoms. But now that our adrenaline has come back down, our body can go through and process and experiences those symptoms that we may have, one, not known about or noticed, or two, subconsciously said, there's no way I have a concussion, or I can't have a concussion because we're in the playoffs and the finals are tomorrow. I can't have a concussion. So it's one of those things that, it doesn't necessarily have to occur right away. For our healthcare workers, especially the athletic trainers, being an athletic trainer in the world, somebody goes through and gets hit, it's really easy to sit there on our end of things and say, hey, we need to evaluate you. We need to see and go, what's going on? We put them through the evaluation. They're reporting no symptoms. And we're kind of like, okay, stop lying to me. I can tell that there's something wrong. But we have to keep in mind that they may not be able to feel the symptoms or experience the symptoms yet because their parasympathetic system, their fight or flight mechanism is so elevated and so energized, and their adrenaline so high that they may not actually feel the symptoms of the underlying injury that's going on. It's a phenomenon that often gets overlooked in concussion diagnosis, that there are some people that go to the emergency room or go to a physician within that first 24 hours and say, look, I'm fine. I'm fine. I'm fine. They get cleared and signed off, and then they go back to the athletic department or the athletic training room or back to school the next day, and their world falls apart. And they're like, wait a minute, I got cleared for a concussion. Why is everything so bad? This is a big one. Sleeping post-concussion is one of the biggest myths that's been dispelled and fought over the course of the last 2 years, specifically in concussion research. There's a lot of studying going on in sleeping right now. A lot of it has to do with NASA trying to figure out how to get people to Mars. A lot of the concussion research that's going on is we realized that the sleeping that was taught, or the keeping people awake for that first 24 hours that was addressed early on in concussion management, was to rule out any significant brain bleeds that may be happening following a concussion. So the idea was you keep people awake as long as possible. You keep them up, you keep them, engaged, you make them count to 10, you make them, you make them say their ABCs backwards to prove to you that they're not deteriorating in their condition. They're not getting worse. They're not getting more disoriented. They're not slurring their speech. They're not having seizures or losing consciousness. But one of the things that we look at now is the sleep within that first 24 to 48 hours is vital. Sleep is when our brain repairs itself. It's when our tissues go through and repair and regenerate. So what happens, and what we tell people within that first 24 to 48 hours is they can sleep, but check in on them. You don't have to physically stay with them. You don't have to walk in and stand over top of them and hover and wake them up and ask them how they're doing. But we want to check in on them periodically throughout that first 24 to 48 hour period to make sure that, one, they're still breathing, and two, they respond to stimulus. What I like to tell patients in that first 24 hours, or tell athletic trainers that I've talked to in that first 24 hours, is if you know or you suspect somebody has a concussion, walk into the room, shake their shoulder. If they move or if they respond to that stimulus, you know that they're alert and oriented to tactile stimulus, so they can feel and they can respond to you moving. A lot of times if you shake somebody's shoulder, they're going to say something to you, or they're going to open their eyes and move around before going back to sleep. They may not physically feel like they're awake, but their body is giving you a response over that first 24 to 48 hour period. The other big one is check in with them before they go to bed. If you have an athlete, or you sustained a concussion, or somebody you know or somebody you live with that you care for sustained a concussion, check in on them before they go to bed. If the injury occurred at, let's say, at a basketball game, since it's basketball season, we'll talk about it. If the injury occurred at a basketball game, they get them home, we evaluate them, we do the initial evaluation, we suspect a concussion, we talk to the parents and tell them, hey, keep an eye on them over this, for these first couple hours before they go to bed, and just have them check in with you before they go to bed. When we see those rapid deteriorating brain bleeds, or those severe red flag symptom causing events, they're going to occur relatively quickly. That if somebody's deteriorating mentally over an extended period of time, or over that short period of time following the injury, then we need to assess and get some emergency room assistance right away. The likelihood that occurs is relatively low, but we always tell people to check in with somebody that we suspect with having a concussion before they go to bed. That way we can get some baseline of a orientation, mental orientation, our cognitive ability, our speech patterns, and just make sure that they're feeling okay before they go to bed. And then the other big one, when I'm talking with professional athletes, with our collegiate athletes, I try to get the roommate involved to try to help sit there and say, hey, look, you're the one that's going to understand or know anything different is going on. If you suspect anything, let somebody know, let the athletic trainer know, let our clinic know. If you're concerned, especially in that collegiate athlete, the professional athlete, they have athletic trainers on staff, let them know what's going on. And our high school athlete, the big thing that I end with all parents is, if you're nervous or something's changed and you're not entirely sure, or you're uncomfortable with something you're noticing, go to the emergency room. Again, most of the diagnostic testing that they're going to do in the emergency room will be to rule out those significant brain bleed incidents. A lot of times that doesn't occur post-concussion, so we never want to tell people to rush to the emergency room. But if you're seeing loss of consciousness or altered levels of orientation initially following that injury, it's always better to be safe than sorry. And then the next myth is there's nothing I can do. We already talked about it. We've touched on it a little bit more. Let's kind of dig deeper into it. The first 48 hours, they're not a set in stone. You're going to be miserable. Good luck. We'll take care of it afterwards. Let's talk about some things we can do to help fix those first 48 hours. The first 48 hours following concussions are critical in many, many ways in terms of optimizing our brain for recovery, limiting symptoms, learning what our symptom triggers are. But what we want to do is within that first evaluation or first 48 hours is to get evaluated by somebody in concussion management. I end that phrase in concussion management because there are a lot of family physicians, there are a lot of pediatricians, there are a lot of healthcare workers that are qualified to identify concussion symptoms. With concussions being such a complex injury, that's one of the reasons why our clinic started. All I get to do all day is look at concussion research, treat concussion patients, learn about concussions, to where in a pediatrician's office or a family practice office, there are so many new research articles coming out. I mean, if you look at the way the world is today, how many things have changed with COVID over the course of 12 hours from initial identification to today? It's still changing on what we know, how we're treating it, what's going on. Now think about, they do that with the common cold, with the flu, any illness that may be, that comes up. They get so many things that they have to deal with that it would be impossible for us to say, hey, you're a family physician or a general medicine doc or a pediatrician that say your job is to know everything about everything. That's tough for anybody to do. So what I always tell patients is whether you're coming to us or somebody else, get the evaluation by somebody trained in concussion management, because your concussion management doc or your concussion management specialist is going to understand the complexity of concussions and give you a more focalized treatment plan and a more individualized treatment plan versus the go sit in a dark room. We've talked about it. Going to sit in a dark room was that old school approach. Now that we have the research behind us, we know that that treatment or that option for concussion management actually makes patients worse and delays recovery. So the faster you get involved, the faster we can do, all of our treatments, the faster we can get everything going. Concussions are very complex. There are a lot of things that cause concussion symptoms. The brain injury and the tissue that's going on and repairing itself underneath is one cause of concussion symptoms. We have neck injury. We have ocular tracking issues. We have balance difficulties. We have psychological issues. We have anxiety. We have depression. We have chemical imbalances. Then we add the external stimulus. We have patients that come to us saying, my friends don't think anything's wrong. They think I'm faking it. I'm letting the team down. All of these things make concussion symptoms worse. And if you don't take the big picture into consideration, you're doing a patient a disservice for your overall treatment plan. Get evaluated within that first 48 hours. We've touched on it. Concussions are very complex. At our clinic, we do a variety of concussion therapy where we're marketed as vestibular therapy. We're thought of as vestibular therapy, but I like to refer to it as concussion therapy because vestibular therapy is only one small thing of what we do in our clinic. We do a combination of manual therapy to treat the neck pain. We do vestibular therapy to fix dizziness and disorientation and balance issues. We do vision therapy to treat some of the ocular tracking issues and some of the eye movement issues and some of the rapid movements in our eyes that give us eye pain, light sensitivity, headache, nausea, vision difficulties, blurred vision, double vision. We fix those through a combination of vision therapy. We use cognitive therapy or speech therapy. With the cognitive therapy that we do in the clinic, we do a lot of short-term memory, object recall, to where we're looking at doing all these exercises together while giving you words to remember, giving you numbers to repeat backwards, saying, give me every animal that you can think of that starts with the letter E, which if you're trying to figure that out, there's very small lists. In one of the exercises that we do, there were a lot of E's on an eye chart. Very small list. So challenge yourself at home. Try to think about as many animals as you can come up with that start with the letter E. I can tell you there are 14. We can come up with 5 without looking at it. So it's really complex, but we have overall treatment plans that we can work with. And the best thing about our concussion clinic is we try to keep everything in-house as much as we can, but we also have a network of specialists that we can use to our advantage. If somebody's not getting better with the ocular tracking issues or the blurred vision is continuing, we have optometrists and ophthalmologists and neurooptometrists that we can refer to treat some of those things with temporary prescription changes, prism glasses, things that can help with our overall treatment that we might not necessarily have that specialty in. We're a specialty clinic that understands what our limitations are. I'm not an optometrist. I'm not an ophthalmologist. I'm not a psychiatrist. But I know that we can treat these things through a group of therapies that if we're not seeing improvement, we have those other therapies available to us. Concussion treatment and concussion management is very individualized. What may work for you may not work for somebody else. We know that we got to get through it. My symptoms are getting worse. One of the big reasons the symptoms get worse in that first initial 48 hours is we don't know what's causing our symptoms. We talked about the adrenaline. We talked about as the tissues heal, we don't necessarily, these neurons are getting reconnected. The sympathetic pathways are getting reconnected, that some of the symptoms that change throughout that first 48-hour period can be debilitating. We didn't really have a headache initially, but when I woke up the next morning, my headache's a 10 out of 10, and it's making me dizzy and nauseous. I'd never got nauseous when it first happened, but now as I recover, I'm getting more nauseous. We also talked about the serious injuries that may occur underneath. Those the subarachnoid hematomas, subdural hematomas, epidural hematomas, bleeds that happen inside the brain that cause swelling and put pressure on the brain, that we know we can keep an eye out for those red flag symptoms: loss of consciousness, slurred speech, uncontrolled vomiting. We don't want you to throw up post-concussion, but when we talk about uncontrolled vomiting, we look for a duration greater than an hour of, hey, we don't stop for very long. But that to us, vomiting is one of those red flags that we may need to do further evaluation and further imaging following that. How do we fix some of those things in that first 48-hour symptom increase? Limiting exposure to screens. That's one of the biggest things that patients come in. I hear that all the time. Is that what I'm supposed to do? Yes. Short answer, yes. We also live in a world driven by technology. So we have things that we can do that we put into place that we help with our patients and talk to our patients about limiting screen time, using blue light filters, using on our iPhones and our Androids, our night shift mode that takes the blue light away that causes the digital eye strain. Placing the screens on a lowered brightness, keeping the lights bright around us so we can see things clearly, limiting our screen time to 10 to 15 minute sections before we're physically getting up and walking away from the computer, giving our time and our system a chance to relax and calm down. I understand the world, right? In a perfect world, you take your screens and you toss them away and you don't look at them until you're better. Work is done on screens. School is done on screens. We shifted to a completely virtual school at the end of last year, beginning of this year. Some schools are still 100% virtual. Now you have somebody with a concussion say, hey, stay off screens. I'm on screens all day. So we give patients time, and we talk about limiting those screen times to what we call symptom-driven activities. So if any symptoms jump 2 points on a scale of 0 to 10, physically get up and walk away from your environment. Go get a drink, shut the computer and just listen. Close your eyes, stop texting. Get off of TikTok, put Snapchat away, stay off Twitter, get away from all the social media that controls our life anyway, and move on and do things that we can utilize as recovery tools. The next big thing that causes some symptom increases is cervical pain or cervical injury, neck injuries. So we talk about 5 easy stretches that we can do right off the bat to alleviate some of those cervical stretches and cervical pain. Very easy to do. I'm going to demonstrate them very quickly. The first one, you sit up nice and tall, hands on the back of your head, and tuck your chin down to your chest. That stretches the back of those neck muscles. We tell people to hold it 10 to 15 seconds at a time. If you get dizzy or nauseous, back off and don't stretch as far. If you get any sharp pain, back off and don't stretch as far. Any numbness and tingling that radiates down into the hands, stop the stretch until we see you next time. Okay. The next stretch is touching your right ear to your right shoulder and your left ear to your left shoulder. That stretches the sides of our necks, and that upper trap helps stretch some of those neck muscles that as we get that injury, we sit and we get really tight. If you look at most of our posture of our patients anyway, of everyday Americans, we all sit like this because we're all used to everything being down in front of us. Our screens, our computer, nothing is up in front of us where it needs to be. Our moms and dads have yelled at us forever, sit up, pull your shoulders back. They were right. So we're alleviating some of those stretches and giving you some of those stretches to help reduce some of the neck pain. So obviously, number 1, straight down. 2, 3, 4, and 5 is taking the hand on the back of your head and looking down into your armpit. That targets the upper portion of those upper traps. It also targets a little bit of that scapula and shoulder stretches to reduce some of the overall symptoms caused by cervical tightness and cervical injuries. Another technique that we talk about is what we call grounding. When patients get dizzy, when symptoms increase, grounding is one of the best things you can do in terms of reducing overall dizziness, aside from removing yourself from that stimulus. So if we get a patient that gets dizzy, we tell them to put as many contacts on a stable surface as possible. Put your arms down on the table, put your feet down on the floor, put your butt in a chair, put your back on a chair, put your head on a wall. As many points of contact with a stable surface as possible. Reduces that sensation of dizziness that may be thrown back to us by our vestibular system. Closing the eyes helps reduce some of that vertigo or dizziness that gets thrown to us by our eyes. And our body getting multiple contacts with a stable point and surface helps to ground us or reduce that swaying feeling that may be associated with vestibular nerve impairment or inner ear issues. And then again, we talked about over-the-counter medications. Want to avoid them at all costs, but don't sit around miserable. If we can use, a Tylenol or an acetaminophen to take that edge off of the headache, it's okay to take every now and again. We just don't want to take it consistently through that first initial recovery period. I'm exhausted but I can't sleep. This is a big one. Concussions, you either sleep too much or you don't sleep at all. And as you go through recovery, you may sleep 12 hours Monday, Tuesday. I may be so tired I can't physically, I gotta lay down and I want to sleep, and then I can't sleep. A lot of that has to do with that heightened sense of your body as it's going through that injury initially. When we go into any brain injury, concussion, that initial response, the brain triggers, when it's injured, it goes, okay, something's wrong. The brain controls the rest of the body. Everything gets elevated. Blood pressure goes up, heart rate goes up, digestion goes down, everything in that I got to fight or I'm going to run away, that fight or flight mechanism gets alert and oriented. And then it takes some time for our body as it heals to get us out of that. So we may have some trouble sleeping. Anxiety and depression increases happen with concussions. One of the things that we deal with is increased anxiety and depression following concussions that can cause us some sleep difficulties. Why am I not sleeping? Will I ever sleep again? I hate that I'm not sleeping. All I want to do is sleep. You fall into that track of, I'm stuck. I can't sleep. All I want to do is sleep. Why can't I sleep? So we get frustrated. That's the psychological conditions that we talk about. Unfortunately, another thing that we see with domestic violence survivors is nighttime is a lot of trigger for a lot of people because it's the unknown. It's dark outside. I live alone. I was attacked at night. What happens when I fall asleep? What noise was that? I close my eyes and I'm in that heightened sense of alertness already from my brain injury. Now I've got the psychological trauma that comes with that heightened sense of, I don't know what's going on. It's dark outside. Is there somebody outside? Is there somebody in the house? It's a very, very dark spiral that causes a lot of sleep difficulties over time. And then again, that chemical change that happens in the brain. The brain, when it gets injured, it disrupts what we call our reticular activating system or our circadian rhythm, our sleep-wake cycles. And there are things that we can do and techniques that we're going to cover here in a second to help you get to sleep a little bit better. Not saying they're going to be those, $1 million reasons why I can sleep. And it's, you changed my life because you taught me these, but they're going to help calm those systems down and help trigger that brain to release melatonin. Box breathing. Box breathing is another technique that we can use to help relax the system, helps us with sleep difficulties. It also helps us overall with our understanding or with our relaxation of increased symptoms. Box breathing is you sit down, you lay down, you relax with your eyes closed, you inhale through your nose for 4 seconds, you hold your breath for 4 seconds, you exhale through your mouth like you're trying to whistle for 4 seconds, and then you hold your breath for 4 seconds. The 4 seconds is arbitrary. It can be 2 seconds if we have breathing difficulties like COPD, if we have somebody who's a smoker, if we have somebody who has pneumonia, COVID, they have some breathing difficulties already. That 4 seconds is a general term. It can be 2 seconds, it can be 3 seconds, it can be 6 seconds, it can be 8 seconds. We want you to be able to get through it without feeling like at the end of the 4 seconds that I got to take a huge deep breath, and then we're counterproductive on what we're trying to do. Meditation and yoga. We have a great partnership with a group called Zen Lab Indy. They've put together concussion yoga for us. Kristen has been phenomenal in the assistance on what we do in terms of concussion yoga, meditation, post-concussion. When we talk about yoga, especially for that middle-aged male population, the male athlete, the older male, it's kind of a laughable suggestion. I'm not going to try yoga. I promise, try it. If you don't have a concussion, if you've never done yoga before, try it. You'll be shocked at how good you feel afterwards. You'll be shocked about the level of anxiety, anger, stress that comes down following yoga. Segmented relaxation is a technique we talk about with all of our patients in terms of relaxation right before bedtime. Laying down in bed, getting comfortable, switching into that night mode where it's like, okay, it's time to go to bed. We break our body into 4 parts: our head, our shoulders, our butt, and our legs. When we're going through, we do that same inhaling through your nose and exhaling through your mouth. With each inhale, we inhale and raise our chest, try to expand our stomach. Exhale, we relax our head into the pillow. And then we inhale and we relax our shoulders. Inhale, relax our glutes. Inhale, relax our legs. Going top to bottom. When you get to the legs, go back to the head and try to sink further and further into that mattress. It helps trigger our body into that relaxation mode and that sleep mode. Audiobooks and podcasts are something that people don't necessarily think about when they think about post-concussion syndrome. You get dizzy, you have vision problems, you have balance problems, screens, TV is a screen. We want to avoid those screen usage when it's unnecessary. Audiobooks and podcasts can help calm our system. It helps bring in that auditory stimulus that's not as harsh to the system as some of the other things that we have to deal with in terms of the vision changes. Audiobooks and meditation and relaxation can all go hand in hand. There are a bunch of resources out there for meditation. There are a bunch of audiobooks and podcasts out there to help you relax. Light exposure and sun exposure, we're going to talk about that here in a second. In Indiana, in the Midwest, it's a little bit difficult to get that direct light exposure. So there are therapy lights and vitamin D lamps that can help us get through some of that artificial sun exposure early on. Big one following concussions is we recommend that people take an initial time to take some time off of work. Usually that 48-hour period is good for you to take that time off of work, get in to get us a specialist and get that evaluation done. It also limits the amount of time and stimulus that we get until we know what those triggers are. It gives us a time to understand and get a treatment plan moving forward. That way you're not coming in to get that evaluation after an 8-hour shift where I've been miserable for the last 8 hours. And then we don't really have an idea of what's causing the symptom versus you're already mentally fatigued, you're already struggling. So what we do when we talk to our patients and do an evaluation is we give you that modified work schedule. With our workers' comp patients, with our adults, we give you modifications to work. We talk about wearing sunglasses and earplugs. We talk about limiting your exposure to common symptom triggers, loud noises, lights, rapid movements. We also give you the accommodations for attendance time frame. Instead of an 8-hour shift, do a 3-hour shift. If you work a physical job that requires you driving a forklift or operating heavy machinery, we recommend you take the time off. It's not worth risking your life or the life of somebody else because you get disoriented and dizzy operating your large machinery initially following that concussion. If you come in and get evaluated by us, we're going to give you excuse notes on why you missed those days anyway. We're going to come up with a treatment plan for you and work with a modification to your work schedule. Same thing with our academics, with our students. We talk about changing and modifying our attendance. We have a zone process that we use for our high school and middle school aged athletes and college aged athletes. that put them in different zones based on how bad their symptoms are initially, and we progress them through the zones as they get better. 90% of our concussion patients that come in, we put in zone 4, which means they get more time to do tests and homework, more time to do their projects, more time to work outside of class, and allows them to take breaks as needed during school. We also give them a little caveat that says attendance as tolerated. If you go to school Monday and Tuesday, you wake up miserable Wednesday, we tell them to take the morning off, take the day off, give that system a chance and those body systems a chance to come back down, and then we go back to that. We give you notes to help get you through school, to keep you in as much as you can, as normal as you can, while still getting through school. The other thing that we do is we avoid weightlifting, physical education. And one thing that people don't really think about, we avoid show choir and band while we're recovering from concussions, loud noises, cranial pressure changes inside the body with instruments and singing, rapid spinning and movements with dancing. We avoid those initially post-concussion. Nutrition and hydration in that first 48 hours and throughout concussion recovery are critical. Your brain's healing tissue. You have to give your brain and body the fuel that it needs to get better. Our body uses water throughout its lifespan to do every cellular function that we have. The general rule of thumb is we want to get an ounce of water per pound of body weight when we're healthy. If you think about it, that is a lot of water that our body uses on a daily basis when it's healthy. Now you add that it's on a concussion. When the brain's repairing itself, it's repairing itself 24/7. Even when you're sleeping, your brain tissue is repairing itself. So we need to make sure that we're giving our body the hydration and the nutrition that it needs to get better. Initially, post-concussion, we want to avoid certain things that cause inflammation in the body. Artificial sugar, alcohol, fast foods, processed foods. Caffeine is on there with a little caveat. Caffeine is bad for our system. It's something that is hard for our brain initially to process. Increases heart rate, causes some difficulty with concussion symptoms. But if you're somebody like me who has a lot of caffeine throughout the day, cutting caffeine out immediately following a concussion, it's going to have some negative impact. It's going to cause you headaches. It's going to give you caffeine headaches, give you fatigue. So what we do for patients like me that have concussion or have caffeine dependencies, that we tell you to limit caffeine as much as you can. If you're a coffee drinker every day, we tell you to limit coffee to 1 cup of coffee a day to curb some of those caffeine headaches, but still reduce inflammation through caffeine intake. Sleeping is another big thing we've talked about earlier. Let's talk about napping. Napping throughout the day is okay, but we want to make sure that all napping gets done before 4 p.m. The ideal time that we talk about for naps is between 1 and 4 p.m. The ideal time frame for nap is that power nap, that 20 to 30 minute nap. It says 26 minutes on the slide because NASA is doing a lot of research and they realize what they call a NASA nap is a 26-minute nap that is the best for cognitive function, overall alertness, avoiding what we call sleep inertia or that disorientation, that fogginess that comes if we sleep for longer than 30 minutes. Ideally, at night, we're getting 9 to 10 hours of sleep at night. That means going to bed earlier for most of us, not waking up later. Unfortunately, with school and work, if anybody asks me, yeah, I'll say the work day should start at 10 a.m. The school day should start at 10 a.m. But shockingly, nobody asks me, and that's above my pay grade. So the way the world works, school starts at 7, school starts at 8, school starts at 9, work starts at 7, 8, 9. To get 10 hours of sleep, that means going to bed earlier, not waking up later. We want to maintain a consistent sleep schedule, going to bed at the same time every night, waking up at the same time every morning, despite whether we're on vacation, whether we're on the weekend, because overall, that's better for our body. Now it's more important post-concussion to try to keep our reticular activating system, our circadic rhythms, keeping our sleep-wake cycle consistent throughout a day-to-day basis helps us get through some of those sleep difficulties that may come. Last thing I want to touch on in terms of optimizing your brain for recovery is supplementation. Supplementation immediately following concussions can help us give that brain and body the nutrition it needs. Vitamin C, vitamin D, vitamin B, specifically B2 and B12, omega-3 fish oils, magnesium are all something that our brain utilizes to reduce inflammation. It helps optimize tissue repair. It helps optimize our recovery for concussions and recovery for all injuries, not just brain injuries. And we want to get that into our system as much as we can initially. The best source for all vitamins is going to be natural occurrences: foods, fruits, vegetables, leafy green vegetables, spinach, beans, legumes, fish. But in the case of a lot of the American diet, we don't necessarily get as much of this as we should. So we talk about supplementation of these vitamins. When you're looking for a certain vitamin or a certain mineral or a certain a supplement to look for, I always tell patients, look at the back, read what the bottle tells you. We want vitamin B. We don't want all the fillers that come with it. We want to make sure that we're getting a natural supplement. All of our vitamins are going to have a natural vitamin recommendation through life, but each individual brand name is going to have a little bit more or less depending on how potent their vitamins are. Read through the label, take it as recommended by that company, but we want to get those vitamins in. The other one listed in here is creatine. Creatine is a newer recommendation for tissue healing post-concussion. Specifically for somebody, it's most beneficial if you've taken creatine before the injury. But creatine is a supplement that's used in our brain to repair tissue and damaged tissue in the body. Same thing, brain's part of the body. It's used to repair tissues inside the brain. So it's beneficial to especially somebody who's taken creatine before, but it's also beneficial for somebody, if you haven't taken creatine, to start a creatine supplementation. With creatine supplementation, making sure you're hydrating really well, because your body has to filter that creatine out, and it's a little bit harder on the body. So if you have kidney issues or you have a liver issues, I don't recommend taking creatine for those patients. But if you're an otherwise healthy person, supplementing creatine initially following the concussion is a good idea. Aerobic exercise is something we talk about through our recovery process. Aerobic exercise is one of those things that we look through and we talk about symptom-driven exercise. We touched on increasing 2 points on that 0 to 10 scale, but we don't want to implement aerobic exercise until after the 48-hour period. Okay, that's one of the big changes in concussion research, is getting in and getting active, getting aerobic exercise to benefit tissue healing and increase blood flow. But we want to wait until after that initial 48 hours, after we've gotten initial evaluation by somebody trained in concussion management. So just to recap, the 3 things that I want you to take away, the big objectives for today's talk: differentiate between concussion myths and concussion facts. You can go out now and go back to your teams, go back to your family members, go back to your friends, go back to your coworkers and say, hey, anything that you think of that you've heard from the concussions in the past, most likely it's changed over the course of the last 18 to 24 months. Got you a chance to look at some of the common ones that we see and kind of help educate you on the right end of things. 2, understand that symptoms initially in that first 48-hour period, it's not a set in stone that you're going to be miserable for 48 hours. Give you some techniques and tricks to help you get through that first 48 hours, get through some of those symptom increases that you can utilize going through and change overall. So the last one, optimizing your brain for recovery initially following concussion through supplementation. I know I've got a couple concussion facts that have come in, a couple questions on supplementation. Aaron, I will answer your question on supplementation. I'll shoot you a message to kind of talk about it. But overall, we want to get through and do all of those supplements that we listed: the vitamin B, the vitamin C, the vitamin D, going through and getting those in the fish oil, getting those into our system as soon as possible post-injury, as long as we don't have any aversion to those vitamin supplements. Okay. If you have any questions, the last thing I want you to remember, if you forget anything that we talked about, concussions are treatable. No matter how long it's been since injury, that may quell our expectations on some of the recovery, but it's not normal to walk around dizzy. It's not normal to walk around disoriented. It's not normal to work out and get headaches and get dizzy after I get through 10 minutes of a workout. It's not normal to avoid getting out of a car and turning to the left, or walking down a hallway and turning to the right because I get disoriented. It's not normal. Concussions are treatable. You may not realize that you have sustained enough force of a whiplash injury. You don't have to hit your head. concussions are treatable.